Good evening, everyone. When women are empowered, societies thrive. When women are nurtured, generations flourish. With this profound thought, I extend a heartfelt welcome to the Ayurveda fraternity from across the globe. Today, we are gathered not just for a webinar, but for a celebration of wisdom, tradition, and innovation, all converging to empower women through the timeless science of Ayurveda. Ayurveda, the ancient science of life, has always recognized women as the pillars of health, balance, and continuity of generations. In this program, we unite distinguished scholars, visionary researchers, and dedicated clinicians who have devoted their lives to advancing women's health through Ayurvedic insights. This global gathering is a testament to the strength of collaboration, the richness of tradition, and the promise of a modern research. Together, we will explore breakthroughs in the managing conditions like PCOS, infertility, endometriosis, and more, reaffirming Ayurveda's relevance in addressing the challenges of today's women. On behalf of the organizing team, I warmly welcome each and one of you, esteemed speaker, honored guests, and passionate learners, to this enlightening journey. Let us embrace the spirits of Ayurveda, share knowledge beyond borders, and inspire a healthier, empowered future for women everywhere. Now, it is my privilege to invite Dr. Anjna Tak ma'am, Associate Professor and Head of Department of Prasuti Tantra and Stri Roga at Faculty of Ayurveda, Uttarakhand University, Dehradun. Dr. Anjana ma'am is a distinguished academician with over 18 years of teaching and research experience, a gold medalist in BAMS and holds MD and PhD in Prasuti Tantra and Stri Roga. She has authored 15 research papers and published 3 books contributing to significantly to the advancements of women's health in Ayurveda. Today, she will be speaking on the very relevant topic, empowerment of women in Ayurveda, Ayurvedic Insights into PCOS and with latest updates. Let us warmly welcome Dr. Anjana Tak ma'am, whose expertise and vision continue to inspire the empowerment of women through Ayurveda. Now, before I hand over the session to ma'am, I would like to do a small announcement, rather not a small but a very awaited announcement. For the past few weeks or so, we have been, listening to a lot of researchers, a lot of great minds who have been working in the field of Ayurvedic research. In this regard, we have conducted a paper presentation competition in the memory of Professor P.V. Tiwari Memorial National Level Paper Presentation Competition on International Women's Day. This was organized by DIKSHA Academy in association with COG of Associations. Now, in this, I must say, we have heard very inspiring thoughts and motivating presentations across these weeks. And I'm very pleased to announce, or very honored to announce, the winners of the paper presentation competition. At the third place, we have Dr. Sri Lakshmi K, Assistant Professor, Department of Kamar Britya, YMT Ayurveda College, Kharghar. Her paper was guided by Professor Dr. V.K. Khori. I repeat, on third place, we have Dr. Sri Lakshmi K, guided by Professor Dr. V.K. Khori. Congratulations, Doctor. On second place, we have Dr. Karthik Hunali, guided by Dr. Girish Kumar SV, second year PG scholar, Department of Kamar Britya at SDM Institute of Ayurveda and Hospital, Bengaluru, Karnataka. And on first place, I congratulate Dr. Maria Dancho, third year UG scholar, All India Institute of Ayurveda, Goa, guided by Dr. Trijali Krishnan, EM. I congratulate all the winners, and I think all the winners are present here.
Thank you, ma'am.
Yeah. If
Thank you.
you have any few words you want to share, you can do right now.
Thank you so much, ma'am. Myself, Dr. Karthik, second year PG scholar from SDMIH. Thank you for giving me an opportunity to be a part of Diksha, and to be presenting a paper which is helpful for the adolescent child also, which will uh, which will enrich our whoever is listening, or whoever is a part of Diksha will get to know what all the treatment modalities can be adopted, because nowadays adolescent anxiety and stress factors are more because of the current competitive mode and digitalization. So thank you, ma'am.
Thank you, Dr. Karthik. Your paper was really indeed very inspirational. Next, we have Dr. Sri Lakshmi. Do you have any few words to convey, Doctor?
Thank you, Doctor. Thank you, the whole team of Diksha, for giving me an opportunity to present my paper. Uh, it was a great event, and I could hear uh, many good, insightful papers, and even I had a very insightful session, very knowledgeable session, and I'm looking forward for more sessions from the whole team. Thank you so much.
Thank you, Dr. Sri Lakshmi. Next, we have our first place winner, Maria Dancho. Maria, do you have any? Yeah.
Good evening,
Yes.
everyone. I'm Maria Dancho. I'm a third professional BMA student from All India Institute of Ayurveda, Goa. I would really like to thank DIKSHA Academy for giving me this opportunity. And it was a really nice experience. I had presented on an app that I am working on. I have developed the prototype. It's on comprehensive women's wellness. Right from her childhood to the geriatric phase. And I was very fortunate to develop this and design this under the guidance of my mentor and also my dean, Professor Dr. Sujata Kadam. And I'm thankful for the suggestions that I have received also during the presentation. So this has enriched the my view of developing this app and given me a lot of inputs. And also I've learned a lot from the fellow participants who were there, especially during the last round and even the round before that. So thank you very much, DIKSHA Academy, and thank you to all the judges that you all had brought for all the inputs and for enriching my academic experience.
Thank you, Dr. Maria. Thank you, Dr. Karthik, and thank you, Dr. Sri Lakshmi. All you are winners, and I would also like to thank all the participants who have, done the paper presentation competition. In my eyes, you all are winners because each and every paper was truly inspirational, and it was really taking Ayurveda to the next level. I think that is what the whole aim of this present competition was. So I would like to thank and I would like to congratulate the winners once again. Now, for the time we have all been waiting for, now let's begin this enlightening journey of learning, sharing, and celebration with enthusiasm in our hearts and inspirations in our mind. Now, before starting the session, I would like to go through a few of the basic instructions to be followed throughout the session. For an uninterrupted class session, use a laptop with high speed internet connection. Please keep your microphone on mute to avoid any disturbances. In case of any disruption, check your internet connection first, and if the problem persists and is within our network connection, kindly raise the issue in the chat box. Filling your full name to be displayed is appreciated. Any questions can be posted in the questionnaire session. All queries will be addressed at the end of the session. Now, without any further delay, I would like to hand over the session to ma'am. Over to you, ma'am.
Thank you so much, Dr. Lakshmi. First of all, a big congratulations to all the winners. A very good evening to all the esteemed guests, my fellow healthcare professionals, and the wonderful women gathered here today. A belated Happy Women's Day to all of you. As you already said, that true empowerment is not a calendar event, it is a circadian rhythm. While the world celebrated yesterday, we gathered today to master the daily science of reclaiming the female from the grip of PCOS. So, before we delve into this topic, I must extend my heartfelt gratitude to DIKSHA Academy for their vision in organizing this scientific discourse. I am also deeply privileged to acknowledge our associated KAGOF, that is Kashyapi Ayurveda Gynecologist and Obstetrician Foundation, and a special thanks for Dr. Anjima, the organizing secretary, for giving me this opportunity. Now, coming to the topic of this meeting today, that is the Ayurvedic Insights into PCOS with latest updates. This topic is essential to bridge the gap between the latest evidence based diagnostic tools and the Ayurvedic concepts of Agni and Avran theory. By the knowledge of these, we can provide women with a precise based holistic recovery that the modern protocol currently lacks. PCOS has evolved from a rare hormonal imbalance to a global metabolic epidemic, now affecting rarely 1 in every 8 women. But recent Indian studies suggest that nearly 1 in 5 reproductive age women are affected. Just take a look at the prevalence then and now. We have moved from an era where PCOS was a manageable concern affecting 5 to 8% of the female population to a modern crisis where global prevalence has surged to 10 to 13%. Historically, PCOS was primarily diagnosed in women in their late 20s and early 30s as a fertility issue. But the latest data reveals a massive shift towards the adolescents and the young adults. Why is this happening? Let's see the probable scientific drivers. It may be due to the lifestyle explosion. The surge in ultra processed food and high glycemic diet triggers chronic hyperinsulinemia. It may be due to environmental factors and it may be because of the circadian disruption. A significant portion of this rising prevalence is attributed to improved detection and refined diagnostic criteria, such as the inclusion of AMH levels in the latest updates, which now allow us to identify the silent metabolic cases that previously went unnoticed. It is due to the Rotterdam criteria expansion. We now recognize non-obese PCOS and ovulated PCOS, which were completely overlooked in the previous era. PCOS represents a profound hidden burden. While clinical incidence rises at 0.8% annually, the disability adjusted life years, that is, the DALYS, measuring the years of healthy life lost, have skyrocketed by nearly 87% since 1990. To provide a complete scientific picture, we must address the DALYS, a metric that measures the years of healthy life lost due to this condition. This DALYS has two components, YLL, that is the years of life lost, and the YLD, that is the year lived with disability. For most of the diseases, YLL, that is death, is the big number. But for PCOS, YLD, that is disability, is a massive driver. While the women rarely die directly from PCOS, but they have to live for decades with infertility, with the metabolic syndrome, with the mental health issues, and cosmetic distress. And this is due to the fact that the disability is starting earlier in the adolescent years and lasting longer due to better life expectancy, but poor lifestyle habits. Now coming to etiology. There is no single cause. Instead, it is a complex multi-systemic disorder involving the hormones, metabolism, and the environment. Here is the breakdown of etiology in two primary categories. First one is the environmental etiology. It refers to the external factors that trigger or exaggerate the underlying genetic predisposition, epigenetic and fetal programming. Due to this, the high androgen exposure in utero can program the fetus to develop PCOS traits later in life, essentially setting the hormonal thermostat during the gestation. The second cause may be because of the endocrine disrupting chemicals like the toxins like BPA, phthalates, or microplastics that can mimic natural hormones and clog the cellular receptors, that is SROTAS, disrupting the endocrine system. And third is the circadian mismatch. Chronic sleep deprivation and exposure to blue light, it disrupts the body's natural rhythms, raising the cortisol levels and interfering with the reproductive hormone signaling. Adiposity and inflammation. This may be a reason as the fat tissue act as an endocrine organ secreting pro-inflammatory cytokines that worsen insulin resistance and create a vicious cycle of metabolic distress. There may be dietary triggers like excessive intake of ultra processed food, like heavy sweets, apatya substances that have the high glycemic meals. This basically it weakens the agni, which I will discuss in the later slides. Also, sedentary lifestyle, a lack of physical activity, that is avayam. It also contributes to low metabolic transformation. Insulin resistance is the primary driver in the case of PCOS. Up to 70 to 80% of women with PCOS have insulin resistance. When cells do not respond to insulin, the body produces more. This high level of insulin acts as a co-gonadotropin, signaling the ovaries to overproduce androgens. This is followed by HPA axis dysfunction. The commander center of our brain, that is the hypothalamus and the pituitary, these become hypersensitive and they produce too much LH and not enough FSH. This imbalance prevents the follicle from maturing, leading to the cyst, that is the underdeveloped follicles, which are seen on scan. There is a vicious cycle of androgen. Excess androgens lead to abdominal fat, and this fat then produces inflammatory markers that worsen insulin resistance, further fueling the cycle. Now, let us see the etiology of PCOS from Ayurveda perspective. The samprapti of PCOS begins with nidan, like improper diet, that is ahara chetu, a sedentary lifestyle, that is vihara chetu, and the mental stress, which may be considered as mansik hetu. These hetus weaken the agni, leading to agni mandya. This metabolic derangement produces am, which along with aggravated cough infiltrates the plasma and fat tissue to cause srotas, avrot, or the physical or energetic blockage of the reproductive channels. This obstruction triggers a multi-doshic imbalance within the ovary. Vat restricts the release of ovum, Pitta halts the follicular maturation, and Kapha facilitates the accommodation of this accumulation of fluid, or we can say the clay into the multiple small follicles, which are known as granthi. Ultimately, this process reaches the stage of Vyakti, which is manifested clinically as irregular or absent periods, as anartha or a chronic lack of ovulation, which may be considered as pushpa adarshan. Modern medical science and Ayurveda share a striking correlation in their understanding of PCOS pathogenesis, where Agni Mandya and the resulting arm formation directly map to the cellular state of insulin resistance and systemic endotoxemia. This metabolic sludge leads to srotovrod, which creates a hormonal signaling blockage within the microcirculation. Also, there is a accumulation of cough, which manifests as a development of multiple immature follicles, that is the cyst, while the visceration of vat, especially the apan vayu, results in anovulation. And finally, the inflammatory ushna of rakt and pitta dushti may be correlated with hyperandrogenism, driving the clinical transition to vyakti through the dermatological symptoms like acne and hirsutism. Let's discuss insulin resistance to have a better understanding of PCOS. The insulin resistant tissues, they reject glucose. This causes internal starvation, triggering the liver to release more glucose and the pancreas to pump out even more insulin. Means there is compensatory hyperinsulinemia trying to overcome the resistance. But there is simultaneous paradox. Some of our cells are not starved, but the situation is exact opposite. They are overloaded with glucose. They are literally full of to the brim. They cannot take up any more blood glucose. This is called overflow hypothesis. This simultaneous overflow leads to hyperandrogenism and ultimately causes acne or cyst or the adipose tissue to accumulate, causing the weight gain. The key concept here is the ovary never becomes resistant to insulin. It is bombarded by high insulin level that the muscles have rejected. This slide explains the core concept of selective insulin resistance more clearly. As you can see here, in PCOS, insulin resistance is not universal across all tissues. It is selective. Think of it like a building where the front doors, that is the muscles, are jammed shut, but the side doors, ovaries, liver, and skin are wide open. There is internal starvation, means muscles and fat cells, they reject glucose due to the signaling defect. Even though the blood sugar is high, the cells are starving. This is why patients feel constant fatigue and have intense sugar cravings. Their brains are receiving hunger signals from the starving cells. But there is simultaneous metabolic overflow to compensate for the jammed doors in the adipose tissue and the muscles and the pancreas. They jump to secrete more and more insulin, and therefore the ovaries and the skin, these are sensitive, they are flooded by the excess. The overflow directly triggers the ovaries to pump out excess testosterone, that is the androgens, and the skin may grow to develop the dark velvety patches, which we say is the acanthosis nigricans. These are the effects of insulin resistance. As you can see here, that there may be hyperandrogenism, follicular arrest, rapid progression of virilization, and unopposed estrogen may lead to the increased risk of endometrial hyperplasia. Now let's see the diagnosis of PCOS. In 2003, Rotterdam criteria established the first unified consensus of PCOS, diagnosing the condition through 2 out of 3 ruling. This involved the ovulatory dysfunction, hyperandrogenism, and ultrasound detected follicles. This shift moved the focus from the previous approach of isolated ovarian cysts to a broader understanding of the syndrome as a complex disorder. But the diagnosis of PCOS has shifted significantly in the last few years. We have moved away from just looking at cyst on an ultrasound to a much more functional hormonal approach. The current gold standard remains the Rotterdam criteria, but in 2023, International Evidence-Based Guideline has refined the rules. This is modified Rotterdam criteria. Let us compare the old criteria with the updated one. The basic requirement is still 2 out of 3 in case of adults, but the first change is in the adolescent diagnosis. In old criteria, the adolescents were often diagnosed using adult standards only. But in modified criteria, both hyperandrogenism and anovulation or oligoovulation must be present strictly. PCOM, that is the polycystic ovarian morphology, is not recommended for the diagnosis within the 3 years of menarche. Coming to the PCOM, that is the follicular count, previously more than 12 follicles per ovary were considered. But in the updated criteria, the threshold is higher, more than 20 follicles per ovary, using a transducer of the higher frequency are now taken for diagnosis. Ovarian volume is maintained as the same, that is more than 10 ml. AMH, anti-Mullerian hormone, was not included in the diagnosis previously, but now it has been included. Now serum AMH can be used as an alternate to ultrasound for detecting the PCOM in adults. For hyperandrogenism, focus was on total testosterone in old criteria, but now the focus is on free androgen index and calculating the free testosterone levels. These are considered now more sensitive. This is a visual depiction of the latest update. In nutshell, PCOM is defined. A definition has increased the follicle count from 12 to 20. AMH is now being used as a surrogate to PCOM in adults. For biochemical testing, free testosterone is preferred, and for adolescents, USG and AMH are excluded. This is very important. Both clinical signs, hyperandrogenism, and anovulation or the menstrual disorders are mandatory. Now, why these updates matter? The answer is to help prevent overdiagnosis. Many healthy teenage girls have multicystic looking ovaries as a normal part of puberty. The latest update protects them from being mislabeled. Many women, especially those who have not been sexually active, they find TVS ultrasounds invasive. Means in those cases where TVS cannot be done, a simple blood test or AMH is now considered a reliable marker for high follicle count. Now, this is a very important slide which shows the adolescent distinction. When diagnosing the PCOS in adolescents, we must distinguish between the developed physiology and the endocrine pathology, acknowledging that the first few years after menarche are a protected window where the body is still learning to regulate its hormonal rhythm. In adults, we follow a standard water time criteria, any of three rule, but in adolescents, we find the must have duo. Especially in the first 3 years post menarche, we move to a mandatory combination. The patient must have both hyperandrogenism and persistent irregular cycles. We cannot diagnose only based on the cycles and the androgens alone. In adolescents, we ignore the ultrasound because multifollicular ovaries are a normal part of the puberty and means the high follicle count and high AMH are normal physiological features of a healthy, maturing young ovary. Using them for diagnosis in this age group leads to a massive overdiagnosis. The word irregular is redefined to give the teenage more biological grace regarding their cycle length, while an adult cycle is considered irregular after 35 days. We don't call an adolescent cycle irregular until it exceeds 45 days. We are essentially allowing the HPO axis the extra time it needs to find its rhythm. Just a minute. Just let me share my screen again.
Sure, ma'am.
Hmm.
Sorry, ma'am, you're on mute. I'm not able to hear you.
Dr. Anjima, can I send my PPT on your WhatsApp so that you can share?
Just a second, ma'am. I'll just confirm with the team.
I think the time limit on my other device is over.
Okay, ma'am.
So you,
No issues, ma'am. Can you share it with Dr. Anjuma, ma'am,
yes,
or any
yes,
from
I
the
have
team?
already shared.
Okay, ma'am. Okay, then I'll be sharing it from my end, ma'am.
Okay,
Uh,
okay, fine.
just give us 2 minutes, ma'am, so that we can work it out.
Okay, okay. Sorry for the interruption.
No problem, ma'am. It's okay.
I have requested to let me share my screen again. Please allow.
Mm-hmm. Just a second, ma'am. I'll just make you the co-host. Yes, ma'am. You've been made the co-host, ma'am.
Yeah.
खोल PPT PowerPoint PPT PDF का
Ma'am, your screen is visible. Can you just make it in
just a
slide?
minute. Yes.
Yes, ma'am. It's visible, ma'am.
May I start?
Sure, ma'am. Please, ma'am.
Yes. So coming back to the topic after interruption, uh, now coming to the mandatory metabolic screening, the diagnosis no longer ends with the ovaries. The latest update mandate that every PCOS diagnosis must be followed by blood pressure check, lipid profile, and oral glucose tolerance test. Metabolic screening is mandatory because PCOS is a systemic cardiometabolic syndrome where silent insulin resistance and dyslipidemia significantly increase the lifetime risk of type 2 diabetes and the heart diseases. PCOS is not a monolithic condition, but the spectrum of four distinct phenotypes insulin resistance, inflammatory, post pill, and adrenal, each required a tailored clinical approach to address its specific root cause. Now, let's see the first type phenotype, that is the insulin resistant PCOS. This is the most common type driven by high insulin levels that signal the ovaries to overproduce androgens and disrupt ovulation. The inflammatory PCOS, which is the second phenotype, stemming from the chronic low grade inflammation, often due to stress or gut issues, which block hormone receptors and trigger androgen production. Third one is the post pill PCOS. In this type, a temporary surge in androgens occurring after discontinuing oral contraceptive pills, typically characterized by sudden onset of acne or irregular cycles. And the fourth one is adrenal PCOS, a specific variant where the body stress response is the primary culprit with the adrenal glands rather than just the ovaries. Further, the PCOS can be categorized in four other phenotypes based on the combination of the features. Now, just look at the type A, the classical PCOS, which aligns with the sunnipathic state involving high cough and meth, that is the insulin resistance, and aggravated pith, that is severe hyperandrogenism. The type 2, that is a hyperandrogenic ovulatory, it is primarily a Pitta-Vata manifestation, where the Agni in the form of metabolic fire is displaced, causing androgenic Ushna symptoms like acne or hirsutism. The type C, ovulatory PCOS, it often mirrors a cuff dominant state of Srutas, Avrodh, or we can say the Sang, or the where the channels are blocked, where mild metabolic sluggishness it exists without the full disruption of ovulation or apanvayu. Finally, the type D, that is the non-hyperandrogenic. It represents a pure kapha-vata imbalance centered on kapha, where the primary feature is the structural this maturation and the movement of the follicle rather than the excess inflammatory or androgenic pith. So we can say that modified criteria or these phenotypes, these perfectly align with our Ayurvedic view of PCOS as a systemic rather than just a localized disorder. This confirms the Ayurvedic view of PCOS that it is not just about ovaries, it is about the Rakta, Med, and Agni. Dushti means metabolic symptoms, or as these are involved, these systems are involved in it. Now, coming to the clinical features briefly, there are features related to hyperandrogenism like hirsutism, acne vulgaris, androgenic alopecia may be there, and there are the biochemical markers of androgen. They may be raised. There may be all ovulatory dysfunction like oligomenorrhea, amenorrhea. I am skipping this and now coming directly to the other metabolic and systemic manifestations. PCOS is increasingly recognized as a metabolic syndrome, as there are manifestations like insulin resistance, acanthosis nigricans, weight gain, the centripetal obesity, and obstructive sleep apnea. Here, one thing I want to emphasize that insulin resistance is not present in every case of PCOS, though it is the most common driver. There may be a lean PCOS paradox, means a lean woman with normal BMI can have hidden insulin resistance, but it is not a universal rule. In these cases, the driver is often the adrenal or inflammatory cause rather than metabolic. This knowledge is of utmost importance because while insulin is the master hormone for the majority, but diagnosing PCOS based solely on the assumption of this insulin resistance can lead to the over prescription of metformin or the other insulin sensitizing drugs and can neglect the stress based or the inflammatory root causes. This slide is regarding the latest USG updates. As I have discussed earlier, the latest USG criteria has changed now. As our cameras improved, we started seeing the follicles in more follicles in the healthy women. To compensate this, the diagnostic limit of the number of follicle is changed from 12 to 20. And there is also a adolescent exclusion, which I have already discussed in the previous slide. These are the long-term metabolic features like cardiovascular risk, diabetes, hyperlipidemia, etc. Now we will take a look at what Ayurveda have to say about it. In Ayurveda, PCOS does not have a single direct equivalent. Instead, it is viewed as a complex metabolic endocrine syndrome that finds its closest correlation under the broad heading of univagal. While modern medicine identifies PCOS via the Rotterdam criteria, focusing on hormones and follicles, Ayurveda identifies it as a tridoshik metabolic crisis where the communication between tissues has broken down. PCOS often presents as a Kaph Vat Pradhan Vyadhi, but fundamentally it should be considered as a Sannipati condition as it involves an imbalance of all the three doshas, that is Vat, Pitta, and Kaph, though their roles differ significantly. Because PCOS affects the reproductive system, that is the Artav and the Shukra Dhatu, the hormones and the metabolism, each dosh contributes to a specific part of the puzzle. Kaph is responsible for structure and fluid. In PCOS, it is usually the primary dosh involved in the physical manifestation of this disorder. Excess Kaph leads to the formation of the cysts themselves. Because of it, there are symptoms like weight gain, sluggish metabolism, oily skin, and the clogging of the channels, or we can say the srotas, that prevents ovulation. Vata is responsible for movement and nervous system. Since the menstrual cycle is a process of downward movement of Apan Vayu, Vata is always involved when periods are irregular. Vata imbalance, it disrupts the movement of the follicle and the timing of ovulation. There are symptoms like irregular, absent periods, painful cramps, anxiety, and thinning of hair. Pitta is responsible for transformation, heat, and metabolism. It governs the hormonal shift in the blood. When Pitta is aggravated, it burns or we can say inflames the tissues, leading to the metabolic and blood related issues. There may be symptoms like acne, excessive hair growth, that is hirsutism, irritability, and there may be heavy bleeding in few cases. Pushpagni Jatharni, which is described by Acharya Kashyap, seems to be very near to PCOS. According to Kashyap, the women suffering from Pushpagni Jatharni will menstruate in time, but it is useless. Vritha Pushpam represents a non-seeding blossom, symbolizing the menstruation without conception or the loss of reproductive potential. Sthul Lomashganda, it depicts with the specific physical traits which mention that there may be strong, thick facial features and hairy cheeks, which in Ayurveda context often point towards a hormonal imbalance. Beyond this link to Pushpagni, Yoni Vyapad, Pushpagni Jatharni, PCOS in in Ayurveda, it represent a complex spectrum of pathologies rather than a single entity. As you can see in this slide, it can be treated as an Anukta Vyadhi, where we diagnose and treat based on the specific dosha. This PCOS it simulates a spectrum of diseases ranging from Artavdushti to Avritva to Granthi to Sthalya and Kafas Prame. So different principles and treatment modalities are followed. These varies from patient to patient, and so don't expect a universal treatment for all. You will be disappointed. The pathogenesis begins with Aharaj, Viharaj and Mansik Hetu with Agni Mandya, leading to formation of Am, which subsequently vitiates Kapha and Vat. This results in Srotovrodh of the Artava Srotas, manifesting as a spectrum of disorders of Artav. Ultimately, this systemic metabolic derangement, it simulates a blend of Sthalya and Kapha Prime and may culminate the clinical picture of Pushpagni Jatharni. Etiological triggers like excessive intake of spicy, salty, or fermented food, along with high stress and anger, that is growth, it specifically vitiates pith and worsens the hormonal profile. Now, coming to the Samprapti Ghatak of PCOS, it reveals a systemic metabolic failure. Here, the dosh is, as I have already told, it is Sannipatik Vyadhi. Doshya here is Ras, Rakta, Med, and Artav. Agni involved is Jatragni and Dhatvagni. This results in Srotodushti within the Artava Srotas, where the pathological sang, that is, we can say the physical blockage of the natural movement of Apan Vayu and release of ovum occurs. Ultimately, this deep-seated imbalance in Ras, Rakt and Artav Dushya manifests primarily at the Falkosh, that is at the ovarian level, and Sarv Sharir, that is whole body, confirming PCOS again as a complex Sannipati condition rather than a localized reproductive disorder. Now coming to the management of this Ayurvedic treatment of PCOS. The Ayurvedic treatment of PCOS is a strategic intervention designed to, we can say, reverse the Srotovrodh, that is the channel obstruction, and restore the systemic Agni, that is the metabolic fire, that governs the hormonal balance rather than mere symptom suppression. Eradication or avoidance of causative factors, that is Nidan Parivarjan, is the foremost treatment in any disease. Then Shodhan and Shaman Chikitsa can be done. I will primarily emphasize the Chikitsa Siddhant. My focus is on the fundamental strategy of reversing the Srotorodh and correcting Dhattvagni rather than merely listing the specific formulations. By understanding the how and why of the treatment protocol, we can tailor the interventions more effectively to the individual's unique samprapti. To treat the PCOS effectively without cookie cutter approach, we must follow the Siddhant, that is the principles of Ayurvedic this management. Here are 3 guidelines for the standard Ayurvedic protocol. Guideline 1, assess avastha, that is state of the disease. We cannot treat lean PCOS the same as obese PCOS. If the avastha seems to be santarpanjanya, that is, if the patient has high BMI and insulin resistance, the treatment must be aptarpan. Use of lekan drugs like Trifla, Vacha and Haritrakhand can be done. In case of aptarpanjanya, means due to undernutrition, that is, if the patient is underweight with high anxiety, the treatment should be Brihan, but always with Deepan to ensure the nourishment, it does not create more cysts. In Ayurvedic management of PCOS, the principle of Avran or the Sanghar Chikitsa must precede any nutritive or hormonal therapy. If reproductive tonics, that is the rasayana, are given while the channels are still blocked by cough and made, we will only increase the cyst and metabolic stagnation. This is a common mistake in treating the hormones while before this, we can say, the clearing the blockage of kapha. In phase 1 Shodhan, where the goal is to remove the avran caused by arm and maid, it can be done by Deepan Pachan using herbs like Trikatu or Chitrakadi Vati. It basically corrects the internal starvation at the cellular level. Vaman is indicated for cough dominance and Virichan is indicated obviously for pith dominance. In phase 2, Lekhan is done. Once arm is removed, then we can use the drugs like Kanchnar Gugul, Varunadi Quat, and Trifla Gugul, etc. In phase 3, the Vat Anuloman has to be done, and which means the Vat Anuloman to restore flow is needed now. Because the doors are open, so we must ensure Vat moves in right direction. Basti, specifically the Matra Basti and the Anvasan Basti with oils like Dhanvantar Tel or Sechuradi Tel can be used. Since the ovaries are located in Apan Vat region, that is Adho Navi, Basti is the most direct way to ensure its normal function. Consequently, an effective clinical approach should be specifically to target the Arthavasrotas using the herbs with Prabhav, that is having specific action on the female system. This includes utilizing the Agnya herbs like Lata Karanj, Pipli to stoke Dhatu Agni, and along with the Granthihar herbs like Varun to act as a natural cyst breaker. We may at this stage use drugs like Pushpanvaras, Nash Pushpantagras, Chandraprabhavati, Vangamasam, Kumaryasaf, Shatavari, and Ashok, etc. Here is a brief description of these three guidelines. True Ayurvedic management of PCOS follows a reverse engineering approach. We don't start with hormone boosters. We start by removing the metabolic waste arm first, then remove the obstruction, and only then, when we notice that the channels are clear, we use the drugs of having the balya and the artha janan properties to rejuvenate the ovaries. Treating PCOS without clearing the avran or sang is like trying to water a plant through a blocked pipe. This slide is to show the power of Anupan. In Ayurveda, the Anupan is the liquid vehicle used to take medicine. It is not just a way to swallow the pill. It acts as a GPS that directs the herb to target tissues and a catalyst that enhances its potency. For Granthi Nashak drugs, the right Anupan can determine whether the medicine reaches the ovary or just stays in the digestive tract. So we should use these Anupans as per the condition of the patient. For the clinical management of PCOS, Vaman is specifically indicated for cough dominant phenotype characterized by obesity and metabolic sluggishness, and conversely, Virichan is used for cough pith nisaran and Vat Anuloman. Erandamuladi Basti can be used, and for Uttar Basti, there are certain formulations like Falgrit, Kasi Sadi Tel, Mahanarayan Tel. Lekhan Basti is of very importance. In obese PCOS, we must emphasize on Lekhan Basti. A standard Lekhan Vasti is a Niruh Vasti. The ingredients are meticulously selected for their Tikshan, Ushna, and Lekhan property. In PCOS, the Lekhan Vasti is the biological drain cleaner. By using a combination of alkaline Gomutra and Lekhniya Dravya like Trifala, we can physically and chemically clear the channels. This allows the body's natural hormones to finally reach the ovaries without obstruction. For Quath or the base, Trifla Quath or Dashmul Quath may be used along with Gomutra, and for Kalk, we can use Musta, Vacha, Trifla. It may be used as per the need of the patient. Bahirparimarjan Chikitsa like Udvartan, Avgas Ved, etc. can be done as per the need. Shirodhara, Nasya, or Shiropicho are particularly useful to normalize the HPO imbalance. These procedures act on heart centers like hypothalamus, pituitary, thereby help to treat we can say the main culprit, LH and FSH secretion. Practicing yoga may be a game changer in case of PCOS. Now coming on the diet. Aharo Param Bhishajya. Diet in PCOS is not about calorie counting. It is about gun or qualities. We use Ruksh and Laghu foods to counter the Snehan effect of the kapha, and by keeping the diet tikt, we ensure that the ushma of the medicines which are using, it stays focused on the ovaries and does not cause any ill effect. We may prescribe the 50% tick rule. We must instruct the patient to avoid viruddhahar, and the patient may have the Deepan Pachan tea or fant in the diet. These are the Pathya and Apatya of PCOS. In this slide, I want to emphasize the strategy of using these drugs or diet without pith flare, that is the aggravation of pith. It is the difference between a controlled fireplace and a firehouse, as you can metaphorically see in this picture. It can be done by combining Tikshan drugs with Tikta Dravyas. We should never give Agnya drugs as Ruksh. We should pair them with something that protects the Raktadushti. For example, giving Trikatu with honey or aloe vera or Grit. Usually, Tiktras is associated with Sheetvirya. However, finding dravyas that are Tikt yet Ushna potency is crucial for treating conditions like PCOS. Here I have summarized a few for your reference like Garuchi, Kirat Tikt, etc. In the last, key take home messages are we must apply systemic logic. As PCOS is a Anukt Vyadhi, we must treat the individual patient with the phenotype precision. Therefore, targeted Shodhan is superior to generalized protocol. Our goal is to move from Pushpagni phase to Shuddh Artav, that is the pure functional reproductive tissue. And in the last, to sum up, I will say that the management of PCOS, we must move beyond a one size fits all approach to a precision based Siddhant, as every patient is unique. So that's all from my side, and thank you all for your patience listening. Over to you, Dr. Anjima and Dr. Sri Lakshmi.
Thank you, Doctor. It was really a very wonderful presentation. I think we have covered everything regarding PCOS, and the Ayurvedic management as well. I hope all the participants who are listening to us right now will be very much benefited with your deep understanding on the subject. And as I said earlier, now the session is open for discussion. So anyone with a question, are please request us to post their question in the questionnaire box so that it can be discussed. Any questions
I,
from participants?
I think there are no questions.
I think the presentation was so clear that they don't have any questions.
Oh, thank you so much.
Um, so I think if there are any questions, the participants can either post their question or they can also raise their hand so that they can ask their questions directly to ma'am. I would request the participants to please make use of this golden opportunity to ask your clinical relevant questions on the subject matter to ma'am. Dr. Savita, do you want to her ma'am to repeat the topic of Tiktarasa? I think she has some doubts in that.
Okay. So I think the doubt is regarding the use of Tiktaras. So it is a
Yes, ma'am.
very basic doubt that in case of PCOS, the symptom is often the oligomenorrhea or the hypomenorrhea. That means either the number of cycles are scanty or the bleeding is scanty. And for that, obviously, we have to use the Agnya Dravyas, which increase the quantity of blood. But this in if we see on the basis of the pitta visheshan, the ocean dravyas, they may lead to aggravation of pith and further worsen the symptoms like these acne and hirsutism and the hair issues. So for that we have to select the dravyas which are having tiktras but not Sheetvirya, because the sheet mostly the Tigras dravyas are Sheetvirya. So we have to precisely meticulously understand the pathology. If we want pit suppression, then we can use the ocean dravyas. And but we in those cases where we want the pit to pacify, and also we don't want to aggravate the cough, as the Tictras dravyas are mostly Sheetvirya, then we have to select these drugs which are having Tictras dravya with ocean potency. So this is the whole logic behind this.
Okay, ma'am. Thank you, ma'am. I think there is a comment from Dr. Snehal Aldar. For one of my patients, after Lekanabasti Virechana and internal medicine, patient again missed her period for 1 month as she discontinued the internal medicine. Uh,
Okay.
so I think that's just a comment from Dr. Snehal. Or do you have any questions? Question, doctor?
See, as this PCOS is not a acute condition. It is usually chronic. Make sure just that the patient is not having the nidan. You have to take the history properly, and usually just one cycle of this matra basti or virechan is not enough. So you can repeat the protocol, and first of all understand the pathology first, do the Nidan Parivarjan, and then repeat the same. Your line of treatment is absolutely right, but one thing I will like to clear that in not all cases we have to do Virechan. As I have already told that if you find the symptoms of cough dominance more, you should prefer Vaman. So Virechan is not always indicated in all the cases of this PCOS.
Okay, ma'am. Thank you, ma'am. Uh, any more questions from participants? Okay, ma'am. I think there are no more questions, ma'am. So
Okay.
thank you so much, ma'am. It was really indeed a very wonderful presentation. And with your permission, shall I conclude, ma'am?
Yes, sure.
Okay, ma'am. Thank you so much, ma'am, for first of all accepting our invitation on this occasion of Women's Day celebration and being here with us. And thank you so much, ma'am. It was indeed a great opportunity to listen to you. And I also like to thank all the participants and all the delegates who are present here. And I also once again would like to congratulate all the winners of Yashodaka, the paper presentation competition. Thank you once again. And thank you once again for your active participation and engagement. To stay connected, please stay contacted with our social media platforms. Knowledge is the treasure of a wise man. So, thank you all for joining us today for this enlightening sessions filled with valuable insights. We appreciate your participation and look forward to continuing this journey of learning together. Until next time, stay inspired. Dear Diksha students, please click and post your valuable comments, feedbacks, and reviews about our platform. We would love to hear you from our about our platform is helping you to mold your profession and excel in your clinical journey. Because the more we grow, the more such amazing members we can bring, of more such amazing participations we can do. The link for the same is provided in the chat box. Please do rate us on Google. So once again, thank you so much, ma'am, for sharing your valuable time with us, and I wish you all have a great evening ahead. Before I sign off, I would like to also thank my wonderful team, Diksha, who have been working day and night for you know the smooth running of this show. So thank you so much. Thank you all.
Okay. Thank you, Sri Lakshmi.
Thank you, ma'am.